Welcome Dr. Atul Sachdev. It's my proud privilege to introduce him. Although I think Dr. Atul doesn't need any introduction in this part of the country. He is presently a consultant gastroenterologist at Max Hospital Mohali, and he has served as former director principal of the Government Medical College Chandigarh, and he has been president of GISI. He's won numerous awards and ovations and has published more than 125 papers in national and international journals and performed more than 50,000 endoscoping procedures. His main interests are luminal gastroenterology, therapeutic endoscopy, and hepatology. And I have two people here in this audience, Dr. Atul and Dr. Raju Singh. Both are sons of our revered teachers, Dr. J.R. Sachdeva and Dr. Achan Singh, and I'm really honored to be with them today. Dr. Atul for his elevation, please. Thank you.
Thank you. Thank you. Thank you, Dr. Karmveer. Thank you, Raju, for getting me here, and thank you for showing a nicer picture of mine with a lot of hair. So it kind of brought back my, well, I think it also told me that I was also young once. Not that I'm old, but still, you know, I was younger in the sense. But I'm going to talk about another problem. Basically, Dr. Ajay did talk about something which is a huge public health problem. I'm going to talk about another disease which is, of course, another large issue in our country. And I was given this task of talking about recent advances in abdominal tuberculosis. So when I started thinking about this talk, I thought, what can I talk about? So I made these few outlines. I thought I'll dwell on these aspects of abdominal tuberculosis, talk about incidence, prevalence, and how the mortality is getting affected, and how MDR is coming back, what is the role of newer diagnostic techniques, especially endoscopic ultrasound, what is the role there, what is the role of various molecular or non-molecular technologies, PCR, including multiplex PCR, what are the drugs that we have, and what are the duration of treatment as far as abdominal tuberculosis is concerned. Now, just to take you back, tuberculosis is a huge problem worldwide, and more than 10 million people contract this disease worldwide every year. And about 0.5 million cases are rifampicin resistant. We talk of rifampicin resistance, and we also talk of MDR tuberculosis. Rifampicin resistance is much more common in MDR tuberculosis, since there are a lot of students here, means that there is a resistance to at least two first-line anti-tubercular agents, isoniazid and rifampicin. 2.7 million tuberculosis patients in India, and we have a very high incidence of 217 per lakh per year. So huge problem, really. And the other issue is that very few people have actually got good access to anti-tubercular therapy. 3 million people worldwide out of 10 million people every year have no access to proper therapy, and 0.17 million of drug-resistant cases have no access to therapy. So these are the people who propagate the infection, and they spread this infection worldwide. So to keeping this in mind, WHO has come up with this end tuberculosis strategy. They're clearly defined goals, which is there. Like we heard Dr. Ajay talk about anti-HCV or HCV eradication program. Here also we have similar guidelines which are there, and the aim is to reduce the incidence and the prevalence of tuberculosis and to make treatment available to a larger population of the world. They have laid down these goals, and of course some of these goals have been met, but of course a lot needs to be done. As far as India is concerned, if you look at three major aspects of tuberculosis, or major issues related to tuberculosis, one of course is the prevalence. The other, I did talk about MDR tuberculosis, and the third is of course its association with HIV. So this is a compilation of the data of about 30 odd countries which are there, which have a very high prevalence, and India actually figures right in the middle of it. We have tuberculosis in high numbers, we have a huge number of MDR tuberculosis, and we have a large number of HIV pool. And HIV, of course, we know the commonest infection in HIV infections is tuberculosis. So this is the data which is there. The incidence is more or less stable. About 10 million people get afflicted every year from tuberculosis. This is the data for the past 2 decades. The HIV positive cases, because of various reasons, has shown a reduction in incidence. But the other good thing is tuberculosis, like you all know, is now a notifiable disease. So because of this, the notification of new and relapse cases has actually shown an increase, which is actually good from a public health point of view. Now we have people who are aware of the number of tuberculosis patients, and we can accordingly tailor our policies and treatment as per these numbers. So if you look at it, 44% of all cases of tuberculosis are in Southeast Asia. And looking ahead at India, India has about 27% of the world's tuberculosis patients, which is almost 3 times the number China has. So it's a huge problem that is there. But the good thing is that the incidence actually of tuberculosis patients here is also reducing. It's in both HIV negative as well as HIV positive cases. This map shows you the number of HIV, number of MDR cases of tuberculosis. Again, India has the highest number of MDR cases in the world. So we actually have lots of problems related to tuberculosis. It's a huge public health problem, and if we need important strategies, it is right here, and we need to, of course, gear ourselves up to eradicate this disease, or at least bring it down to manageable levels. So the other thing that I want to talk about is the MDR tuberculosis. If you look at this data, this is a very nice study which was published a few years back, where they isolated samples from pulmonary and extrapulmonary sources, and they looked at the incidence of MDR isolates. The MDR isolates were about 11%. So that's the kind of figure that we have. The figures are, there are some studies which show that the incidence of MDR tuberculosis in our country is closer to 20%. Now, the association of MDR tuberculosis is with HIV is very well known. When we look at HIV negative persons, or rather the extrapulmonary tuberculosis, if we look at HIV negative people, they have only about 15% of extrapulmonary disease. But if we look at HIV positive, the proportion of extrapulmonary tuberculosis actually increases to about 50%. So meaning thereby that if a person is HIV positive, the incidence of extrapulmonary tuberculosis is very high in comparison to people who are HIV negative. Abdominal tuberculosis is responsible for 10% of all extrapulmonary tuberculosis. It's the 4th commonest site after pleura, lymph nodal, and bone involvement. The problem is with diagnosis. Abdominal tuberculosis is not easy to diagnose. This is also the case with all extrapulmonary tuberculosis diseases that we encounter. One, the symptoms and the signs are non-specific. They're not specific for tuberculosis. There is no single specific test. And tuberculosis, like we say, can mimic any disease. Even pregnancy, of course, can be mimicked by tuberculosis. Radiology is non-specific. It's a paucibacillary disease. So because of these reasons, we can't really pick up tuberculosis early. It's a lot of times you need to have a high index of suspicion before you can say that this is actually looks like tuberculosis and make a positive diagnosis of tuberculosis. Now there are certain criteria which have to be fulfilled, or at least one of these criteria has to be fulfilled, and these are age-old criteria which were laid down in 1964 by Postian. That means that one of these criteria, any one of them, if it is positive, would indicate a positive diagnosis of tuberculosis. That means presence of caseation in granulomas, presence of AFB either on smear or in histology, or having a positive culture of AFB, or having histological and microbiologically confirmed tuberculosis at one site, and having findings which are consistent with tuberculosis in another site. So that is the other diagnosis. And of course, you know, a lot of times, like I said, it's very difficult to make a positive diagnosis of tuberculosis. There was a modification which was suggested by Logon in 1969, and that was called the response to therapy. That's another acceptable criteria for making a diagnosis of tuberculosis. So when we say it's a confirmed case of tuberculosis, abdominal I've mentioned here, but whenever we say this is a confirmed case, there are two things which must be shown. One, of course, is AFB. Either you show the presence of AFB in tissue or fluid or in culture, or you show the presence of caseation in the tissue. So that's a confirmed diagnosis. Otherwise, you say a clinically diagnosed case, you have histology showing granulomas, or if you have fluid collections, whether it's peritoneal or fluid or pleural, you have to have high ADA levels along with low SAG, or you have to exclude other conditions by of course looking at tissue samples, or you have to have a positive response to ATT. So that's the kind of criteria which you need for making a diagnosis of tuberculosis. Now, abdominal tuberculosis is classified into these four types. Either you can have lymph nodes, or you can have just the involvement of peritoneum, or you can have involvement of a solid organ, or you have the luminal involvement, that is the GI tuberculosis. You can also have a combination. The common ones, of course, the commonest is peritoneal tuberculosis, which is most often encountered in the form of a wet acidic type, or it could also be in the form of a dry plastic type of peritoneal involvement, which could actually present with obstructions or have a cocoon-like presentation. The other, of course, is GI tuberculosis, and here is the ileocecal tuberculosis, which is the commonest, most commonly involved site in tuberculosis. So this is the peritoneal type. You have the wet acidic type, and whenever you have fluid anywhere, the standard golden dictum of teaching is if you have fluid anywhere which is abnormal, you must tap it, analyze it, and try and get a positive diagnosis. So that's the important thing. You need to tap it. It could be a free fluid or it could be actually loculated, but you must tap it and analyze it for the characteristics of tuberculosis. A typical tubercular effusion will have lymphocytic predominance, will have low SAG, and an ADA which is generally more than 32 units. So that is the specific thing you make a diagnosis. The pickup rate of AFB, pickup rate of granulomas or caseations is very low. I'll talk a little bit about this in a little while. Now, ADA, of course, has now become a standard for diagnosis of effusions, whether it's ascites or pleural effusion. Diagnostic sensitivity is close to 90%. If we combine it with a low SAG, the sensitivity and the specificity is even better. There are other markers which are there, but like I did say, the AFB positivity is very low. You can actually just maybe pick up AFB on smear in about 3%. Culture positivity is about 20%. So it's a diagnosis which is generally made on the basis of ADA, lymphocytic predominance, and a low SAG in acidic fluid. So this is what I mean, that if you look at peritoneal tuberculosis, AFB positivity is only 2.9%. Culture, much better, of course, but still very low, 34% or so. And if you do a PCR in peritoneal fluid, the figures range between 48 to 75%. If you do a PCR with only one sequence, the sequence which is used for the primer sequence which is used for tuberculosis, IS6110, has a low specificity, but if you do a multiplex PCR, the sensitivity is much better. I'll talk about this. So the other advancement that has taken place in abdominal tuberculosis is the role of endoscopic ultrasound. There are two types of endoscopic ultrasounds. You have the radial and you have the linear. You can actually take biopsies or you can take tissue samples from the areas which are close to the gut lumen. You can see what is endoscopic ultrasound. Basically, again, for the benefit of the students here, is that there is an endoscope and there is a piezoelectric crystal which is fitted at the end of the endoscope, which vibrates at variable frequencies, and it gives you a very good image close to the gut wall. You can see the mucosal details, you can see the lymph nodes, and if you find a tissue there or a mass there, a needle can be put through the through the instrument channel of the endoscope, and biopsies can be taken. So that's now been used very often for diagnosis of tuberculosis. Now its usage is in various organs. It's of course often used for diagnosis of esophageal tuberculosis. Esophageal tuberculosis actually is a very rare disease, but it can be actually diagnosed easily with the help of EUS and biopsies. Generally comes with dysphagia. You do an endoscopy, you find a little submucosal elevation, or you find an ulcerated lesion. You do a CT, it will show you some lymph nodes there. You do an EUS, it may show a lymph node, and you can take an FNAC from there and get a diagnosis very quickly. So that is the role of EUS. This data shows that if we do just the endoscopic biopsy or do a combination there, the pickup rate could be as high as 84% for diagnosis of tuberculosis. Same thing can be used for gastric tuberculosis also. You see, these tuberculosis basically, these are very rare situations. Esophageal and gastric involvement in tuberculosis is very rare, but it can have various kind of manifestations. One type of manifestation is a large ulcer. But if you have an ulcer, you can take biopsies and of course try and pick up tuberculosis, but sometimes it just presents as a submucosal tumor. So there, EUS plays a very important role. Actually, you can identify the structure, put a needle and take tissue and send it for analysis and get a positive diagnosis. Duodenal tuberculosis, not any different, but very rare disease. We currently have a patient admitted with us who's got a stricture in D2. We did an EUS, but we are awaiting the results of the biopsy. That, of course, is a great investigational tool to pick up diagnosis of tuberculosis. Again, pancreatic tuberculosis. This is all extraluminal. It's very difficult to approach these areas. So, what generally EUS does is it gives you images, and you have an instrument channel. You can put a needle through that and get tissues. So, this is an advancement which is there. As far as management of abdominal tuberculosis is concerned. Another, of course, is the EUS for picking up from tissues from the peritoneum. This is a very interesting study which was published from Gangaram, and they picked up biopsies from omentum through EUS and gave a positive diagnosis of tuberculosis. So that's another advancement, the role of EUS in diagnosis of tuberculosis. Another advancement is, of course, the technologies which are now been endorsed widely by the WHO. We are aware of the usage of GeneXpert, which is now as a part of our NTCP program. We are using it across the board for diagnosis of tuberculosis and for picking up rifampicin resistance. Line probe assays are also being used, and the good thing is with line probe assays we can actually pick up resistance against isoniazid and rifampicin at the same time. There are other techniques which are of course been recommended. The light emitting diode microscopy has changed the way we diagnose tuberculosis. The culture media have changed. Now we have a faster turnaround. You can actually show the growth of tubercle bacilli within 2 weeks with the help of MJIT or liquid media, and then of course run the DST on that and try and get a diagnosis. So these are technologies which are advancements. They are not necessarily advancements which have taken place recently. They've been there for the past 2 weeks or so. So in a way, they have changed the way we manage our patients with tuberculosis. So that's about GeneXpert. It's got a good sensitivity, good specificity. If we take 3 samples, the sensitivity is much better, but if we pick up something, of course, it's got a great specificity. There are now next generation GeneXperts which are now available. They are being tried in different countries of the world with good results. They're better than the currently available GeneXperts. And of course, similarly, there are other cartridges which are now being made available in various tuberculosis program across the world, where they can simultaneously pick up resistance to various drugs which are being used for tuberculosis. Gamma interferon assay, again, not an advancement, but it's been used. It's actually release of gamma interferons on stimulation, by MTB antigen. It does not get affected by previous BCG, but it's got a poor sensitivity, does not differentiate between latent and active tuberculosis. Role in intestinal tuberculosis is yet to be defined, but role in peritoneal tuberculosis it's been shown to have a sensitivity in the range of 70 to 80%. Another technique which is there, a lateral flow lipoarabinomannan assay, which is there, but this is recommended for HIV patients with low CD4 levels. They said you look for this assay in the urine. This is now almost universally recommended for diagnosis of tuberculosis. What about PCR? I did talk about this. I talked about a single primer PCR, but it's got a low sensitivity, variable sensitivity of about 30. Some studies go up to about 80%. The other thing, if the problem in India is that possibly 10 to 15% of isolates of tuberculosis don't have this sequence in them. So you should not use this insertion sequence 6110 for Indian isolates. So that's why a combination of various primers is being recommended, and that's the basis of this multiplex PCR. Following the use of multiplex PCR in GI tuberculosis, another very nice study was just published from PGI, where they looked at the importance of looking at various tissue samples, and they did PCR, compared it with smears, with cultures and histopathology, and they found that if we apply a multiplex PCR to tissue samples, the sensitivity is very high. Of course, the specificity is close to 100%. So that's another advancement which is there, and I think that's an important tool in the hand of gastroenterologists for appropriately or adequately diagnosing cases of tuberculosis. Skin tests, very important. Some modifications are being done, but more data is needed before we can actually recommend these skin tests. Another advancement has been in drug therapy. We used to say for tuberculosis, please give 9 months therapy, or there were certain other people who would say give therapy for 12 months. And we did not know should we reduce the therapy. Longer therapies are associated with poorer adherence, with risk of drug resistance, was associated with increased costs. So there were 3 studies. One of them was, of course, done by Govind, who is unfortunately not here today. One study was done by Govind. It was a multicentric study. And another study came from Korea. The third, of course, was a single-centric study from India again. So these are 3 studies which were done. They had almost 300 odd patients in them, and they compared 6 months therapy with 9 months therapy. So they found that 6 months therapy was in no way less than 9 months therapy. So thereby, there were only 2 relapses in these patients at a follow-up of 12 months, and that is why the recommendation emerged that 6 months therapy for tuberculosis is good enough, at least for visceral and peritoneal tuberculosis. There were no lymph nodal cases in these 3 studies, and of course HIV patients were excluded in these 3 studies. Following this, there was a Cochrane database or a systematic review, which was again done by Vineet from AIIMS, and the recommendations there also were 6 months regimens are not inadequate than 9 months regimen. However, the number of patients in these studies was small for a huge country like ours, but still the recommendation is that please stick to 6 months therapy for tuberculosis. And this is also formed the basis for the index guidelines, the Indian extrapulmonary tuberculosis guidelines, of which I was also a part, and the guidelines gave a recommendation that 6 months therapy for abdominal tuberculosis is good enough. Now this was a real world study, that was the recommendation. Again, this was a real world study which was done in PGI, just published this year, and they did a retrospective analysis of about 100 patients. They had 93 patients of tuberculosis, and they looked at the efficacy of 6 months therapy. The follow-up was short, 6 months follow-up only, and they gave the standard therapy 2-HRZE, 4-HR for 6 months, and had a 6 months follow-up, and they found good results with no relapses, practically no relapses. So thereby meaning that 6 months therapy for tuberculosis, abdominal tuberculosis, is good enough. In this study, there were 5 patients with lymph nodal tuberculosis, but I think still a person like me would still be hesitant for lymph nodal tuberculosis. I would not like to give 6 months therapy. Probably I would like to still give maybe 9 months of therapy for lymph nodal involvement in patients of abdominal tuberculosis. So we need, the other issue that we are facing is ATT for MDR tuberculosis. Efficacy is only 56%. Efficacy for XDR is only 39%. So we need to have more drugs, we need to have better regimens. 3 other drugs which have now been recommended, bedaquiline, delamanid and proteomanid, these are recommended by the FDA. Bedaquiline is now a part of the RNTCP program in our country for treatment of MDR and XDR tuberculosis. Whole lot of other drugs are being developed, at least 23 more drugs are being developed, and some of them are in phase 3 trials. A lot of other regimens are being tried. I think we will have better regimens for treatment of MDR and XDR tuberculosis in the years to come. So, Mr. Chairperson, Madam Chairperson, I'd like to conclude my talk by saying that abdominal tuberculosis accounts for about 10% of all extrapulmonary tuberculosis cases. Since it's a possibacillary disease, no specific signs, no specific test, no specific radiological finding, to make a diagnosis we have to have a high index of suspicion. It's always better to show the presence of AFP or caseation to have a reliable diagnosis, and of course 6 months therapy is adequate for visceral and peritoneal tuberculosis and possibly for lymph nodal tuberculosis. We need more data before we can make a strong recommendation on duration of therapy. Thank you very much.
Yes, any questions or comments?
Sir, do you have
Dr. Katoch,
No, I think very well balanced actually analysis. Only one addition, Dr. Sachdev, actually. Besides the gene expert, our own Indian toolnet, which has now been recommended, at least for the pulmonary TB and a huge number of cases, and that has proved to be better than gene expert. And so there's certainly, we have a better Indian option, which is as robust or perhaps better. So far it is better. And I think we'll have the data for the extrapulmonary also. It should be the same. It won't be different there also. So I think then in your future slide you add that also.
One
more
thank you
slide.
very much, sir.
Yeah,
Thank you.
yeah,
I was not actually aware of this, but thank you for sharing.
No, this is not
Thank
published. Not published yet. This is still part of ICMR report.
Right, sir. Right, sir. Thank you very much.
But
sir.
very balanced review actually.
Thank you, sir. Thank you, sir.
sir, how often do you encounter abdominal tuberculosis in your cases or something?
See, I'm a gastroenterologist, so all
Yes.
I deal is is with abdominal tuberculosis. Generally we don't see pulmonary or other organs getting involved. So I just, if you see as a practice, of course, as overall, like I said, maybe we see about
20%.
maybe, I mean, it'll be wrong to say give you the thing, but on an average we see about maybe 10 new cases of abdominal tuberculosis. Ascites, of course, is very common, but about 10 new cases of luminal involvement, and considering that we see about 200 patients per week, so that's the kind of diagnosis that we get.
Sir, excuse me.
Sorry.
Sir, regarding ADA values in cirrhotic patients, what is the sensitivity and specificity, because cirrhosis being a immunocompromised condition, can we rely on the ADA values in this group of patients?
Very good question. In fact, there is data to show that even in presence of cirrhosis, ADA is as reliable. So if you have an ADA which is more than 32, of course there's a problem with protein because overall protein is low, but then you do look at SAG there also. You compare it with the serum albumin, and if you have a low SAG along with ADA which is more than 32, even in the presence of cirrhosis, you can make a confident diagnosis of tubercular peritonitis.
Sir, sometimes like we see mixed ascites in these patients, high SAG, high protein with ADA values sometimes 20-25, lymphocytic predominant. How to approach then these patients?
Yeah, in such cases, you see, you have to have a suspicion there. If you can send it for say PCR, the pickup rate, like if you do a multiplex PCR, the sensitivity could be in the range of 80 to 90%. So multiple primers can be added, and if you show the presence of or show a positive PCR for tuberculosis, you've kind of made a diagnosis. The other thing would be to, of course, treat with diuretics and see the response with diuretics, and then subsequently on follow-up, tap again and try and get a diagnosis.
And CBNet also, sir?
Same thing basically. You can run it. The pickup rate is like is lower. PCR has a better pickup rate for that. No, I'm not the expert. Maybe Dr. Katoj can add to that. I'm not an expert on that.
Distinguishing the Crohn's disease from the intestinal TB. Those are a series of papers which came from first Italy, then India also, many of them. But then certainly because the pathologists didn't adapt the technology that much. Otherwise the specific diagnosis would have enhanced several fold. Somehow, our pathology colleagues have moved more on the, I don't know, there is a different universe. So,
So I was looking at, of course, when I was looking at this data, I was also looking at, ways to differentiate between Crohn's and tuberculosis. This is a continuous dilemma which we all face. Now I looked at the PCR for Crohn's and for tuberculosis. The sensitivity is only 67%. Overall, this was a systematic review. So we really can't rely on that for making a diagnosis.
No, but Dr. Sachdev, that's okay. That's on the work done so far. But if the pathologist would have adapted the in situ, see, in situ actually just removes the dilemma. You're showing the sequences in the lesion, and that's how the papilloma story came actually. So 2003 onward, the diagnosis was in situ only. That showed that is right in the lesion.
Yeah.
And it is almost with 100% certainty this distinguishes the Crohn's disease from TB. If it is a mycobacterial etiology. If because in the Crohn's also section of them the mycobacterial etiology is there actually. Not in all, but in a small section it is there actually. So when it is AFB, when there is a granuloma of that kind, then it shows the way. Yes.
If I may just, for my knowledge, sir, what were the primers used in that for in situ? Did they use IS 6110 or?
I'll send you the data, but
Right, sir,
yeah.
Because 10 to 15% of
Yeah.
Indian tubercular isolates,
They won't have.
they
that.
don't have this IS
Oh, yeah,
6110, sir.
I'll show that actually.
So that's why even if you use various other primers, sir,
Yeah.
if you use multiple primers, even there the sensitivity is about 90%. So there is of course some more data which needs to be generated before we can make
sure.
a positive recommendation for in situ.
No doubt. That work should be done actually. That
Yes,
should be
sir.
done.
Yes, sir.
Dr. Atul, thanks for a nice talk. I
Thanks,
wanted to
Vikas.
ask you,
Thank you.
what is the role of capsule endoscopy in intestinal tuberculosis? Are we still doing it, or previously we used to do it?
No, can be done. I mean, basically, but you have before you resort to this, you must rule out intestinal obstruction. You should say that there is no obstruction. That is the first thing. The other thing, of course, is capsule will show you lesions. You can't really biopsy them. That's the other thing with this. Of course, it's always better to have a biopsy. Like I said, it's better to demonstrate the presence of caseation or AFP. Capsule is a good investigation. It will show you the small bowel. But a lot of time you have extraluminal involvement, and CT enterography or CT enteroclysis, or for that matter MR enteroclysis is a better investigation to my mind than capsule endoscopy for picking up luminal involvement.
And I think now the latest recommendations are that we are giving HRE for the
That's
continuation
right.
phase.
I didn't talk about that, of
Oh,
course. That's another topic
So
in
that-
itself.
Thank you.
I think for the last 2 decades we have been following dots in RNTCP on alternate regimen. Do you think somewhere we are responsible for propagation of the MDR or XDR tuberculosis, because the outcome was not as expected, so it led to MDR and XDR, and now fortunately we have shifted to daily regimen for the future. I think that's another factor which I think to me it's a big contribution in that.
Yeah, I think you're right. Maybe Sir can talk about this. He's the right person to talk
Clinicians
about
over
that.
the years have been insisting on Delhi regimen.
I know Sir can. He's the right person to talk about
I think,
this.
sir, I'll answer you. The evidence based, there's something like a voting in an election, and a science. Science is a debatable based on record. We analyzed this question just before my retirement. There was this question posed. They wanted to change from an intermittent to
Delhi regimen.
and I asked for, it's okay, you come with the data. So next time they came with beautiful data for the HIV. So in HIV, definitely the daily regimen is far better than the intermittent one. But there was not a single evidence to show that it was better in the pulmonary. So the pulmonary, it was more of impressions. It was more of a political decision. I said, if you're a senior professor, why don't you publish?
Yes.
Being a professor means you should be a researcher also. You should be
Absolutely.
an academician also.
Absolutely.
So as a consultant, you are different. So the 10 consultants voting for a regimen, I don't accept that as evidence. But for the HIV, definitely there was evidence. For the other side, there was no evidence, zero evidence. It was a political decision taken. Well, they did it. They waited for my retirement. That's it.
Okay. One thing that happened when we used intermittent therapy was the incidence of ATT-induced hepatitis came down.
Yes.
Again, I think there's some data to show that there was a reduction in ATT. Maybe Professor Chawla can add to that. The incidence of ATT-induced hepatitis came down. Vis-a-vis, when we used to give daily therapy, the incidence of ATT-induced hepatitis could be as high as 10 to 15 to 20%.
Again, it was surprising because that in alternate regimen the doses were very high.
Higher.
Higher than the daily regimen. Anyway.
See, very interesting. There's a regimen which is being tried for treatment of tuberculosis. That's a high dose rifampicin regimen which is being tried. The dose which is being recommended is 35 milligram per kg. We give about 10 to 15 milligram per kg. Here, it's almost 2.5 times the dose which is being recommended. There's a phase 3 trial going on that. So, well, let's see what happens actually.
Thank you once again for
Thank
an
you.
excellent presentation.
Thank you. Thank you.
Dr. Atul, any no more
Thank you.
questions? Thank you.
Thank you so much, sir. With this, we end our session. I would like to request our chairpersons to kindly felicitate our speaker. Now I would like to request Dr. Chawla to kindly felicitate our chairpersons. Dr. Rumpa Saha. Dr. Rumpa Saha. Dr. Karamveer Goyal. Thank you so much, sir. Now, with this, I would like to start our next session, gut microbiome.